My goals for today are to help you understand, or help all of us understand, the social determinants of health that create ethnic health disparities and racial health disparities, and that how these disparities negatively influence health outcomes, and understand how cultural responsiveness can help mitigate those health inequities, and also to explore ways to adopt a family-centered and community-based culturally responsive practice. I'm going to be doing this today by telling you a story, and this is my story and my journey taking care of my own patients, and how cultural responsiveness has helped me to practice medicine from a place of empathy, and has helped me to address my own unconscious biases, so that I could care for my patients and their families in a way that is respectful for who they are, of their own history, their culture, and their individual needs, so that we can be equal partners in their healthcare. So in order to tell you my story, I want to start by telling you a little bit about myself. So I spent the last 20 years as a pediatrician working in underserved, under-resourced, marginalized, and vulnerable communities of Brown and Black people. I run a mobile clinic that provided free medical care to homeless children. I was a medical director of a juvenile detention center. And I've spent the last half of my career working primarily with Spanish-speaking immigrants in Northern California in the Bay Area. But in this picture, this was the beginning of my career. This is my graduation from medical school. And on my right is my maternal grandmother, whose parents illegally immigrated from Mexico in the early 1900s, and who eventually became citizens and moved their family to Detroit, Michigan in the north, looking for better opportunities for their family. And on my left is my paternal grandmother, whose own grandmother was a slave, and who grew up and started raising her own family in the Jim Crow South. In the 30s and 40s, and who eventually moved her family up to Detroit, Michigan as well, also looking for a better life for her family. And on this day, I became the first person on either side of my family to become a doctor. I didn't have any ambitious or lofty goals, or what I thought were ambitious goals. I was optimistic, I was hopeful, and I just wanted to be a good doctor and to help my patients be healthier and live happier lives. So a few days after this picture was taken, I packed up my car and I moved across the country to Oakland, California, where I started my residency at what was then the Children's Hospital Oakland. And there I took care of a lot of Black and Brown people like me, and like the people I grew up around all my life. And I worked with some wonderful doctors who really cared about the community. And I learned a lot about plain old simple bread and butter pediatrics, treating asthma and anemia and ear infections. But I quickly found myself frustrated, overwhelmed by the realization that what I was doing was learning to put a Band-Aid on some problems that were so much bigger than anything I was being trained to do. And the problems that my patients and their families went home to after they left my brief clinic visits, or even extended hospital stays with them. And what I was coming up against, I didn't know it then, but what we now know are the social determinants of health. This is a concept that W.E.B. Du Bois noticed in 1906, before either of my grandmothers were born, that it wasn't genetics or even necessarily individual behaviors that impacted the health of Blacks and Brown people in our country, but racial disparities in where and how they lived that led to worse health outcomes and higher mortality rates. And it wasn't until 2010, more than 100 years later, when the United States federal government formally recognized that social conditions, specifically the social determinants of health, were responsible for the racial health disparities that W.E.B. Du Bois saw, and that I was seeing, and that everyone who's cared for patients of color has seen and continues to see every day. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. And they're influenced by economic, political, and social factors. All the factors that are shaped by the allocation of money, power, and resources among different communities. And they are directly and inextricably linked to avoidable and preventable health inequities that we see in our patient populations. It wasn't until 2019 that the American Academy of Pediatrics released a statement that finally acknowledged that racism is the core social determinant of health that drives these health inequities, because of the role that racism plays in determining where, how, and why people of color find themselves living, growing up, and working in certain environments, as well as because of the inherent damage done to people who endure racism itself. Racism is a social determinant of health that has a profound impact on the health status of children, adolescents, adults, and their entire families. It defines where we live because of practices like redlining. It defines our access to healthy foods and whether or not we live in a food desert. It defines what kind of education we're allowed to get because of the schools and the areas we grow up, what jobs are available to us, how safe our community is, our exposure to air pollution and toxins, and factors like whether or not we have access to parks and green spaces. This algorithm it was created by the Asthma and Allergy Foundation of America, and it shows how systemic racism results in health disparities by a complex interaction of factors that lead to poor health outcomes among people of color, and why these factors lead to communities of color facing the highest burden of disease. Because of algorithms like this about asthma, we know that people of color, like African Americans, are more than 1.5 times more likely to have asthma, 5 times more likely to go to the ER for asthma flares, 3 times more likely to die than whites. And honestly, you could put any number of health outcomes into this complex algorithm and find the same complex interaction of the social determinants of health, leading to the same poor health outcomes. It's race and ethnicity in, and poor health comes out. And racism affects children's lives in many, numerous, and complicated ways. They're more likely to have asthma because of their exposures to air pollution, more likely to have cognitive impairment and brain and nerve damage because of lead exposure, more likely to have cancer because of lack of access to care and delayed diagnosis. So many problems that everything, it seems like everything we study that has worse health outcomes, we see, in fact, impacted by this algorithm of the social determinants of health on race. And all of these disparities have really come into the light of day, especially with the COVID-19 pandemic, because of where and how people of color live. They're more likely to have jobs that don't allow them to stay home and shelter in place. And as a result, have higher rates of COVID-19 infection. It passes down to their kids. African American and Latino or Hispanic kids have higher rates of COVID-19 infection and have higher rates of the multi-system inflammatory syndrome in children, which is a really rare complication that we see with kids. But when we see it, we tend to see it in populations of color. Racism also affects their children's health because racism is stressful. Children experience racism vicariously by seeing their parents, their family, the people around them in their neighborhoods experience racism. Through personally mediated racism by how they're treated by their teachers, shop owners, law enforcement, and by internalized racism, because eventually, after seeing all this and having all these experiences, they believe that what society is telling them, that they're inferior, that they have less worth. And as adults, when they study kids who have experienced racism in any of these forms, they find that when children experience these forms of racism and they talk to them again as adults, their stress response is comparable to first responders after a major disaster. It's this ongoing stress. And prolonged exposure to these stress hormones like cortisol leads to inflammatory reactions, oxidative stress at a cellular level, and results in what we know as toxic stress or allostatic load. That predisposes these individuals to chronic disease like cancer, diabetes, hypertension, infections. And it also affects their mental health. Children who are targeted by racism are more likely to have depression, anxiety, behavioral problems. They're more likely to be withdrawn, participate less in class, and get lower grades because of those interactions. And we as healthcare providers are part of the problem. We know that patients of color experience racism in their direct encounters with their healthcare providers through how providers perceive and treat them. Healthcare providers are less likely to spend time with their patients of color, less likely to involve them in decision-making, and are even less likely to give them pain medication. And this study's been done with adults, but also with children. Providers in the ER have been seen to be less likely to give children pain medication when they come in with a fracture or an appendicitis. But the next slide, I want to talk about how healthcare providers are assets and how we can help to address some of these problems. Because when you think about all the things I was talking about when I left off before that disturbance, it's easy to feel overwhelmed and really helpless, like I was feeling when I was a resident, and was feeling really overwhelmed with how little impact I was having on my patients in terms of affecting their lives when they went home. So whenever this happens, I feel like it's important to take a deep breath, kind of be reflective, and think about what we can do as providers to address these problems and to affect change with the power that we hold. My ancestors survived centuries of racial oppression and degradation by using the old adage, making a way out of no way. And so I feel like sometimes we as healthcare providers need to adopt some of that. And when we're facing these uphill or what feel like uphill battles, to forge ahead with that same level of resiliency and hopefulness, and if we're lucky, with joy and love in our patient practice and in our clinical practice. So for those of us who are called to do it, it's so important to do research and make systems and policy and environmental changes that will help overcome those racial disparities that are caused by the social determinants of health. But in my heart, I'm a primary care pediatrician, and I always have to look back, excuse me, at what I can do today in my clinical practice. When I go see patients this afternoon, or when I call a patient this afternoon, what can I do to make their lives just a little bit better? And one of the concepts we hear about a lot is the concept of implicit bias. The concept that we all have unconscious biases that impact how we value, group, treat, and engage with people every day. I love the idea behind implicit bias and the concept that we need to be aware of what's going on within ourselves, that we need to be reflective. And what we know about implicit bias is that these biases are learned, but there seems to be evidence that we can unlearn them if we can know that they exist and respond to them. Oops, excuse me. So, all right, let me take a breath, find my place. There's evidence that that implicit bias training can help us learn that implicit bias training or de-bias training can help us overcome these unconscious biases. But I worry that that people will think that they can overcome all of the unconscious biases that they spent a lifetime developing after one de-bias training, and that they'll think they never have to come back to combat those biases again. Okay. So I worry that de-bias training isn't enough, that people will think that they can do a de-bias training once or even once a year or once every 4 years, and that it's going to combat all of their unconscious biases. And so this is where I think cultural responsiveness comes in. Cultural responsiveness is another framework to help us achieve our ultimate goal of having equity and respect in developing the ability to learn from and relate to our patients and to people from our own culture, as well as from people in other cultures. This picture is a picture of my daughter trying to figure out what's going on with this tree's root system. And it always makes me think of what cultural responsiveness is, because it's all about curiosity. It's about trying to figure out where we are and what's going on and what's happening and how we're all connected. Cultural responsiveness combines commitment to lifelong learning, which is what I love about it. It's the concept that we always need to be curious. We always need to keep exploring what's happening. And it involves cultural competence and cultural humility. It promotes the understanding, it promotes the idea that we need to understand our own culture, ethnicity, and language, as well as the culture of people around us and the patients we serve. And it implies that we can never be perfect. We can never attain all of the skills we need. So we need to keep continuously working on developing our understanding. So I want to take a step back and just for a second talk about what culture is. Because culture is this umbrella term that encompasses basically everything that we are. And it's not just a list of traits, like what's our ethnicity, our race, our class, our religion, but it's the idea that we all have our own unique story, our own unique heritage, and our own unique social identity and beliefs that define who we are and how we interact with the world. Cultural competency is the process of learning to understand our own culture, to acquire knowledge and skills about the culture of others, and to engage in self-assessment and really understanding and acknowledging those cultural differences to be able to view our own behaviors and the behaviors of others in a cultural context. When I think about cultural competency, I think about studying. And so I think that it really is a great place to start for those of us in healthcare, because we're really good at studying. And it's all about learning about different cultures, reading books, joining book clubs, attending diversity-focused conferences, maybe taking the implicit association test and seeing where that puts you, interacting with diverse groups and with people who are different or have different ideas or backgrounds than you have. I think there are a lot of positives to this approach because you're learning so much about other people. But I also think there are shortfalls for cultural competency because it supports the myth, or it could support the myth, that cultures are monolithic, that there's one Black experience or one Mexican experience or one white experience. And of course, there's not. And it also supports the idea that you can become competent in someone else's culture or someone else's experience. And I think that limits how much you can learn, because it makes you feel like you can stop learning. Oh, I read these books, or I attended this conference, and now I can stop learning, which is why I think cultural humility is so important. It's such an important component of the cultural responsiveness model. Cultural humility involves critical self-reflection, always. It involves redressing the power imbalances that are inherent in any doctor and patient relationship or client relationship. And again, that lifelong commitment to learning, to being curious. When I was a resident, one of the things that saved me was that I had the honor to work with and learn from Melanie Turvalon and Jan Marie Garcia, who developed the concept of cultural humility. And it really helped define how I work with patients and how I view my relationships with patients. I think it's the heart and soul of cultural responsiveness. Because it always takes me back to a time when I was an optimistic resident and I just wanted to figure out how to help my patients and to be hopeful about what could come out of those interactions. It reminds me that no matter how much I know or how much I'm an expert in a field, that I'm only one of the experts in the room when I'm in a room with my patients. It reminds me to always, always be curious, to embrace what I don't know, which is something different for most medical providers or healthcare providers, because we spend so much time trying to be an expert, trying to know everything and master everything. And cultural humility reminds me there's a lot I don't know. And it reminds me to believe what my patients tell me about their experiences, and to admit when I'm wrong, and to approach my work and my patients with acceptance and love as a partnership. Cultural humility is different from other de-bias trainings or culturally based training ideals because it really focuses on self-humility rather than achieving a state of awareness or particular knowledge. And it helps you use what you've learned in cultural competency to guide you, but not to define you and not to define your interactions with your patients or clients. And I think it helps us better understand the communities we serve so that we can get to know what they want and what they need. And to know that they're in the best position to tell us what they need. I think kindergarten is taking a break. You guys hear that excitement? The model that I like to use for implementing cultural humility in my practice is the humble model. And it reminds me that cultural humility is about reflection, being humble about the assumptions that I make based on my own background, culture, and my own biases, motivating myself to learn about other people, incorporating that knowledge into my work, and really just making the patient a partner in their care and being committed to constantly learning, always learning, everyday learning. And the more you practice it, the better you get at it, the more it becomes natural to you, even in a high pressure, fast paced atmosphere of a busy clinic. So when I'm trying to learn a new concept, I find that anecdotes are more powerful than data. So I'm going to go back to my story and how cultural responsiveness has helped me build a family-centered, community-based practice. And I want to share with you some of my successes, but also my mistakes, in the hopes that you can learn from my experiences. So for the past several years, I've worked in a lifestyle clinic with families who are primarily Spanish-speaking immigrants. For most of them, the parents immigrated to the US and the children who are my patients were born in this country. I work with a diverse and supportive team of awesome providers. And our goal is always to help these families. The families we treat are at high risk for developing lifestyle-related illnesses like diabetes, hypertension, high cholesterol. And our goal is to help them develop healthy lifestyles so that they can eat healthier, get better sleep, have decreased screen time, and be more active and play outside so that they can take control of their own health. Our team takes a family-centered approach to care, which means we try to actively engage the families in their own care. We work with them to come up with their own goals to improve their lifestyle habits. And the family-centeredness of our care helps us develop relationships and trust with those patients. So we've evaluated our program, And what we found when we evaluated it was that we're really good at helping families improve the way that they eat by removing soda and juice and processed food from their home. We're really good at helping them decrease screen time. But what we didn't do well when we evaluated our program was we didn't do a very good job of helping them be more active and spend more time playing outside. This was especially difficult for me because I'm all about nature. I'm a trail runner. I go on hikes with my family. I commune with the trees. And I know and understand the physical and mental health benefits of being active in nature and just being in nature. So I made it my personal mission to try to convince my patients that they needed to take their kids to the park and explore nature. And so notice that I said convince. The minute I start trying to convince my patients to do something, I'm bringing my own agenda into the room, my own biases into the mix. So when you start trying to convince your patients, your clients to do something, it's a manifestation of our own frustration as a provider. And it means that we're disengaging from our families, which is the opposite of cultural humility and cultural responsiveness. So when I started proselytizing to my patients about the benefits of nature and the joys of nature, perhaps because they knew I meant well, or more likely because they were disengaging from their visits with me, my patients would be very sweet. They'd say, okay, that sounds great, we'll do that. And then they'd come back the next month and they wouldn't have done it. They would make up excuses. It was too cold, it was too hot, we were too busy, they had too much homework. And when providers start to feel like patients or families are making up excuses, it's another sign that we're disengaging from them. And usually they're saying those things because they're feeling like their needs aren't being met and they're not being understood and they don't feel welcome or comfortable. And for me, this went on for more time than I like to admit. And I really didn't realize or understand what I was doing to my family until I had a child of my own. And becoming a mom was, like, for many of us, the most humbling experience of my life, but also the most enlightening. For my personal experience in pregnancy, I started feeling things I hadn't anticipated that I was going to feel. I found myself wanting to move outside of my culture of traditional Western allopathic medicine, all the things I had been trained to trust. I wanted to ignore all the recommendations about having a medicalized childbirth, about co-sleeping, about breastfeeding. And I wanted to have a childbirth experience and a parenting experience that was similar to what my distant ancestors had experienced in Africa and in Mexico before they were enslaved, before they were colonized, before they were conquered. What was that experience like for them? I really wanted to go back and have that experience for myself and for my child. And I started to feel disengaged, kind of hostile towards my own medical providers and even towards my own colleagues who would give me advice and who just didn't seem to understand how my perspective had changed. And I realized it was because they hadn't asked me how my perspective had changed. And all of a sudden, I realized that I had been doing this to my patients and their families, the people that I love and care for. I had been shutting them out of their own care, overpowering our visits with my own agenda and my own expectations and my own frustrations, and shutting their voices out of the care of their own children. So I took a deep breath, did a lot of self-reflection, went back to my humble model, reminded myself that families need different approaches based on their individual needs. I reminded myself to be curious. And I started trying to learn how to forgive myself and hoping that my families would forgive me too for letting my own biases come into my exam room. So when I came back from maternity leave, I was very contrite, very humble. I apologized to my families. I said, wow, I'm starting to get it. And I started to ask a lot of curiosity questions. What do you feel like when I tell you that it's good for you to take your kids out and be active in nature? What do you think? What do you want for your kids? What's keeping you from getting those things? What's standing in your way? And what they told me was that when I talked to them about nature, of course, they wanted all of those things for themselves and for their kids. They wanted to see all the images I was telling them about and the things that I was proselytizing about. But they just didn't see that happening for themselves. What they thought of when they thought of their local parks near their homes was about gangs in the parks, or drug dealers, or homeless people with untreated mental illness that frightened them. And when they thought about going to parks that were away from their home, they thought about how they didn't drive, or if they did drive, they weren't used to going outside of the areas they were comfortable going to. They told me they didn't know the difference between a park ranger and an ICE agent, and they were scared when they saw somebody in uniform in the parks. They didn't feel comfortable. The signs weren't in Spanish. They couldn't read the signs. They didn't know if there were warnings that they needed to be worried about. And they worried that if they overcame all of those obstacles, they would take their kids to these parks and the kids would be bored and they wouldn't want to be there. And it made me realize that even though I see myself as a woman of color with this background that is so similar, but not the same as my patients, that I have been blind to all of my unconscious biases, born from my own privileges, my privilege of language, of citizenship, of transportation, of familiarity. And it made me realize that as a member of a privileged group, it's hard to see your own privilege. It's difficult to see the system of inequity that privileges us. So once I knew that this is what my patients were experiencing, and I started to understand the problem and some of the barriers that were keeping them from getting what they needed, what they wanted, my next challenge was to find a way to help them overcome those barriers. And it wasn't simple. It was nothing I could do to calm those fears. And I needed to find a way to advocate for them. So that's where community-based medical care comes into play. It means that in addition to engaging our families and finding out what they need, that we need to do some asset mapping in the community and find allies that can help us help our patients. And there are lots of potential allies out there once you start to look for them. Our lifestyle clinic had already partnered with the community farm that was giving free produce to our families. We partnered with a local gym that was giving discounted memberships to them. But at first I had a hard time finding someone who was working to overcome the barriers that my families had identified for me. And I eventually found an ally in my local public health department. Or really they found me, because I made it known far and wide that I was trying to find ways to address this challenge. So my local public health department had partnered with 20 parks, and they had received a grant to help families from high-risk communities gain access to parks and green spaces. And they reached out to my health system to try to find someone who might be interested in working with them. And someone is improving my slides. I love it. So they reached out to my health system, and eventually they found their way to me, because I had made it known that I was interested in doing this work. And I partnered with them, and we decided that my team in our clinic would start to write park prescriptions, and that our patients would, we would take our patients out for walks because the patients indicated that that's what they wanted to do. And we hired a Spanish-speaking community worker and who would call every single family who received a park prescription and make sure they had a way to get to the park, make sure they felt comfortable. If they didn't have a way, we used the grant to provide a taxi service that would go to their homes, pick them up, bring them to the park, and then take them back at the end. We work with the parks so that if there was a car seat involved, they could store the car seat safely during the walks and have it installed back into the taxi on their way home. We had a wonderful park interpreter in uniform who tried to speak Spanish and who tried really hard to make sure the families felt welcome and to make sure the walks were interesting and engaging for the kids. And so that our families would feel more comfortable, the community worker who called them and someone from our clinic came to all the walks. And this is a picture of our very first walk, and I am far behind the group, as you can see, with my daughter. And this is the way that I experienced most of our walks, was my daughter wasn't always feeling social and didn't want to be with the group. And at first I was really worried that that was going to be difficult for us, that I wasn't going to be a part of the group. But what happened at the end of this walk was the families met us on their way back. And I saw one of my families and I saw one of my patients, this 12-year-old, and I was so excited and so hopeful. And I said, you know, how did you like the walk? What was it like? And she said, oh no, I hated it. It was the worst. It was too hot. It was too long. I didn't have a good time. And I was like, oh my gosh, okay, we failed, but we're going to work on it. We're going to make it better. It's just the first walk. But then I looked at her mom, and her mom was glowing. And she said, this reminds me of where I grew up in Mexico. And I feel so connected to my history and to my family. And don't worry about my daughter. I'm going to come back the next walk with her cousins and my sister and my mom, and we're all going to come, and my husband's going to come, and we're going to keep coming, because this is exactly what we need. This is where we want to be. And I knew that we had some things to fix, but that we were on the right track, that I had listened and it was paying off in terms of helping my families feel empowered, feel like they could have those experiences they wanted. What we noticed over time was that as we continued to have our walks, the family started to build this community. We were building a community about being active in nature. You would see the taxis pull up to the park and the parents would get out and hug each other, hug us. The kids would run to play together. And what I noticed was that this was also influencing what was going on inside the clinic. Because now when my patients would come back the next month for the next clinic visit, they would say, you know, we've been seeing you for so long and we feel like we need to tell you that, you know, I'm a victim of domestic violence and I need help. Or my husband's an alcoholic and we need support. All of a sudden, they realized that they could talk to us, that we were connected, that we cared, that we were listening, that we wanted to hear it. And it just really changed my whole practice. Families would come to the first visit with us and say, I can't make any changes. We're overwhelmed. We can't manage anything. And I would say, just come to a park walk. And they would come. And then the next visit, they would say, okay, if we could do that, we could do something else. We can't make big changes, but I think we can make a small change. So over the course of the next few years, our park prescription program grew. We had over 2,000 participants in our park walks. And it's really been one of the most powerful experiences of my career, because I've been able to engage with these families and connect with them. And they see that my life's not perfect. They see me at my park walks with my daughter, and they give me parenting advice. You know, we really have equalized our interactions. It's so powerful. And so I think that It's helped empower us now to start using our experiences to advocate for change on a broader scale and to make some systems, policy, and environmental changes that will further help to remove our barriers so that more families can get access to the parks and green spaces. So the message I want to leave you with today is that each of us has the capacity to be introspective, to be reflective, to be curious, and to approach our patients and their families with humility, and to build a dynamic and culturally responsive relationship that accepts and respects them and helps empower them in their own care. And this is one really important and essential way that we can help mitigate race-based inequity. We all have power to be a part of the solution if only we're brave enough to see it, and if only we're brave enough to be it.
Thank you, Laurie. That was amazing. I see folks are getting emotional. It's like a whole thing.